Human papillomavirus, HPV, is a ubiquitous double-stranded DNA virus that infects epithelial cells of the skin and mucous membranes. The virion is roughly 55 nanometers in diameter and consists of a protein capsid composed of L1 and L2 proteins that encases the viral genome. Transmission occurs primarily through direct skin-to-skin contact, especially sexual intercourse, but perinatal transmission can also happen during childbirth. Because most infections are asymptomatic and resolve spontaneously, HPV often goes undetected, yet it remains a leading cause of benign warts, precancerous lesions, and several malignancies, including cervical, anal, penile, and oropharyngeal cancers. Its public health impact is amplified by the fact that over 80% of sexually active individuals will acquire at least one HPV type in their lifetime. More than 200 HPV genotypes have been identified. Low-risk types, most commonly 6 and 11, are responsible for the majority of benign genital warts. High-risk types, especially 16, 18, 31, 33, 45, 52, and 58, possess oncogenic potential because their E6 and E7 proteins can inactivate tumor suppressor pathways. Major risk factors for acquiring a high-risk infection include early onset of sexual activity, having multiple concurrent sexual partners, and immunosuppression, for example HIV infection, organ transplant immunosuppressive therapy. Cofactors such as cigarette smoking, prolonged use of oral contraceptives, and chronic inflammation of the cervical epithelium increase the likelihood that a persistent high-risk infection will progress to dysplasia and eventually carcinoma. HPV gains entry to basal epithelial cells through microscopic abrasions. Once inside, the viral genome is transported to the nucleus, where early genes E1 to E7 are expressed. The viral oncoproteins E6 and E7 bind to and promote degradation of the host tumor suppressor, proteins P53 and retinoblastoma RB, respectively. This disables cell cycle checkpoints, leading to uncontrolled proliferation of the infected keratinocytes. The virus also employs mechanisms such as downregulation of major histocompatibility complex, MHC class, 1 expression and secretion of immunomodulatory proteins, for example E5, to evade immune detection. Over months to years, these molecular disturbances can manifest as exophytic warts in low-risk infections, or in high-risk infections, as cervical intraepithelial neoplasia, CIN, that may progress to invasive carcinoma if not cleared. Globally, HPV infection is one of the most common sexually transmitted infections, with an estimated prevalence of 80% among sexually active individuals. Incidence peaks in adolescents and young adults 15 to 29 years, reflecting the onset of sexual activity. While women are routinely screened for cervical abnormalities, men also serve as reservoirs of both low and high-risk HPV and can develop anal, penile, and oropharyngeal cancers. High-risk HPV prevalence is higher in low and middle-income countries due to limited vaccination coverage and screening infrastructure. In contrast, high-income nations that have implemented national vaccination programs targeting girls and increasingly boys have observed a substantial decline, up to 70%, in vaccine-type HPV among adolescents within a decade. The majority of HPV infections are clinically silent and resolve within 12 to 24 months. When disease manifests, low-risk types produce soft flesh-colored exophytic lesions known as genital warts. These can appear on the vulva, penis, perianal area, or oral mucosa, and may cause pruritus, bleeding, or discomfort during intercourse. High-risk infections seldom produce overt symptoms. Instead, they generate microscopic cellular abnormalities detectable by cytology or pap smear, or HPV DNA testing. Persistent high-risk infection can lead to cervical intraepithelial neoplasia, CIN1-3, which is asymptomatic but may progress to invasive cervical cancer if untreated. In the oropharynx, high-risk HPV can cause persistent sore throat, dysphagia, or a non-healing ulcer that may herald squamous cell carcinoma of the tonsil or base of tongue. Clinical diagnosis begins with a visual inspection for warts or suspicious lesions. Cervical cancer screening employs cytology pap smear to identify abnormal squamous cells, often followed by high-risk HPV DNA testing using PCR-based assays or signal amplification methods, such as hybrid capture-2. When a lesion is identified, a colposcopic examination guides directed biopsy. Histopathologic evaluation reveals characteristic coilocytosis in low-risk lesions or dysplastic changes increase nuclear to cytoplasmic ratio, mitotic figures in high-risk disease. Immunohistochemical staining for p16-INK4, a surrogate marker overexpressed when high-risk HPV disrupts RB, aids in confirming oncogenic infection. For non-cervical sites, tissue sampling via excisional biopsy or fine needle aspiration is used, with subsequent HPV genotyping to guide management. HPV genotypes are categorized primarily by oncogenic risk. Low-risk types, principally HPV 6 and 11, are associated with benign anogenital warts and respiratory papillomatosis. High-risk types HPV 16, 18, 31, 33, 45, 52, 58, among others, are causally linked to malignancies of the cervix, vulva, vagina, penis, anus, and oropharynx. The International Agency for Research on Cancer, IARC, designates these high-risk types as Group 1 carcinogens. Clinically, HPV infections are also stratified by anatomical predilection: genital, cervical, penile, anal versus cutaneous, common warts on hands and feet. This classification influences screening protocols, vaccine formulation, and therapeutic decision-making. Management depends on disease manifestation. For external genital warts, first-line options include patient-applied topical agents such as imiquimod immune response modifier or podophylax antimitotic, and provider-administered ablative therapies like cryotherapy, laser ablation, or electrosurgery. Precancerous cervical lesions, CIN2/3, are treated with excisional procedures: loop electrosurgical excision, procedure LEEP, or cold knife cone biopsy, to remove the transformation zone while preserving fertility when possible. Ablative techniques, for example CO2 laser cryotherapy, are alternatives for selected cases. Invasive HPV-related cancers follow standard oncologic protocols. Early-stage disease often warrants radical surgery, for example hysterectomy, for cervical cancer, while locally advanced disease requires concurrent chemoradiation, cisplatin-based, and increasingly immunotherapy, for example PD-1 inhibitors such as pembrolizumab. Post-treatment surveillance includes periodic cytology HPV testing and imaging as indicated to detect recurrence. Prophylactic vaccination is the cornerstone of primary prevention. The bivalent vaccine targets HPV 16-18. The quadrivalent vaccine adds protection against HPV 6-11. The nonavalent vaccine covers 9 types: 6, 11, 16, 18, 31, 33, 45, 52, 58. Recommended schedules consist of 2 doses for individuals initiating series before age 15, and 3 doses for those starting later. Immunization programs now include both genders, beginning at ages 9 to 14, and extended catch-up vaccination up to age 26, or older in some health policy contexts. Secondary prevention relies on organized screening, cytology every 3 years, or primary HPV DNA testing every 5 years, depending on age and resource setting. Complementary public health measures, comprehensive sex education, condom promotion, and improved access to vaccination clinics further reduce transmission and disease burden. The natural history of HPV infection is largely self-limited. Over 90% of infections in immunocompetent hosts clear within 2 years without sequelae. Low-risk infections that produce warts are generally benign, with cure rates exceeding 80% after appropriate therapy. High-risk infections that persist for several years increase the cumulative risk of progression to high-grade lesions and invasive cancer. Early detection via screening dramatically improves outcomes. Cervical cancer diagnosed at stage 1 has a 5-year survival greater than 90% in high-resource settings, whereas late-stage disease drops below 50%. Prognostic determinants include tumor stage, patient age, smoking status, and immune competence. For example, HIV-positive individuals fare worse. Regular follow-up after treatment, clinical exam, cytology, and HPV testing helps identify recurrences when they are most amenable to salvage therapy. Current research focuses on therapeutic vaccines that aim to eradicate established HPV infections by inducing robust cytotoxic T-cell responses against E6/E7 oncoproteins. Candidates include DNA-based, peptide-based, and viral vector platforms currently in phase 2/3 trials. Broader coverage prophylactic vaccines, for example, 12-type or pan-HPV formulations, are under investigation to extend protection to additional oncogenic genotypes. Liquid biopsy technologies are being refined to detect circulating HPV DNA or P16 mRNA in blood or saliva, offering non-invasive early cancer screening. Immunotherapies such as checkpoint inhibitors, pembrolizumab, nivolumab, have achieved durable responses in recurrent/metastatic HPV-positive head and neck cancers, prompting studies of combination regimens with radiation or therapeutic vaccines. Digital health interventions, mobile reminder apps, SMS outreach, and telemedicine platforms are shown to increase vaccine uptake and adherence to screening schedules, especially in